Hi, my name is Lindsey Roeker. I am an assistant attending at Memorial Sloan Kettering Cancer Center in New York City and the CLL program director here. And today it is my pleasure to talk to you about future directions in the care of patients with CLL. And we're really focusing on updated data that we've gotten throughout 2023, and there will be three major focuses today. So the first section will be looking at novel combinations. The next we'll be looking at new agents under development, and then last we'll look at advancements in the treatment of Richter's transformation, which is definitely an area of unmet need in CLL. So without further ado, we're going to start with doublet and triplet therapy. So this is a series of presentations, papers, abstracts that really focus on novel combinations, meaning BTK inhibitor plus venetoclax-based combinations. The first study is maybe, in my mind, some of the most exciting data that we had presented in 2023, and this is the FLAIR study. So FLAIR has an adaptive design. It's a really cool study where we're looking at multiple parallel arms. So there was FCR, there is ibrutinib with rituximab, there's ibrutinib monotherapy, and then ibrutinib with venetoclax. And this is an analysis of ibrutinib and venetoclax versus FCR. So the primary endpoint here is progression-free survival, and this is our look at these data. So patients who required frontline therapy with CLL who were no older than 75 and did not have more than 20% of a deletion 17p by FISH were randomized to receive either 6 cycles of FCR or ibrutinib and venetoclax. And this was given for a total of 2 to 6 years, and it was MRD adapted. So we'll talk about how the duration of therapy was determined based on this study at the next slide. This is a schema that shows us how we think about therapy duration for the study. So patients had serial MRD checks by flow with a 10 to the minus 4 sensitivity throughout their treatment duration. And when a patient was found to have undetectable MRD, they then had a repeat test 3 months later. If that one was undetectable, then they had peripheral blood and a bone marrow biopsy 6 months after that first test. If all 4 of those tests were undetectable, then the first time point where it was checked was when they were considered undetectable, and they received therapy for twice that duration. So if it took a year to be undetectable, you get 2 years of therapy. If it took 3 years to be undetectable, you get 6 years of therapy. And the idea here is based on some modeling that suggests that not only are we trying to get people MRD negative, but we might be able to achieve a functional cure, with the idea that if you really drive the CLL into such a deep remission that there are only minuscule numbers of cells left, then potentially you could have this functional cure. And that was the idea that this study was built on. So a look at the outcomes data. These arms were fairly well balanced in terms of baseline characteristics as well as high risk features. There were a couple, tiny little differences here. So trisomy 12 was a little bit more common in the ibrutinib and venetoclax arm, normal karyotype a little bit more common in the FCR arm, but overall pretty well balanced. And on the bottom left-hand side, you will see the primary analysis, the primary endpoint. So this is progression-free survival. Blue is I plus V. The red is FCR. You can see that I plus V has a really significant progression-free survival benefit with a hazard ratio of 0.13. In an interesting turn, overall survival is actually also improved for I plus V over FCR. So you can see that there were 9 deaths in the I plus V arm, there were 25 deaths in the FCR arm, and that is a significant difference. So we see both a significant improvement in progression-free and overall survival, particularly for unmutated patients. So when they broke it down into looking at those with mutated patients, the progression-free and overall survival benefit actually isn't there. But they then also broke down by cytogenetics and found that regardless of cytogenetics, there is a significantly improved PFS. So particularly for those with unmutated FCR and regardless of cytogenetics, there is a progression-free survival and overall survival benefit of I plus V when compared to FCR. And I think this is a great study because that control arm is a real treatment. We've seen a lot of things compared to obinutuzumab and chlorambucil, or treatments that we're really not using. And FCR, I think, was a solid control arm in this study. So that's an overview of FLAIR.
Just curious, the obvious question is where would, for example, BTK alone fit on that curve, or where would venetoclax with the obinutuzumab fit on that curve?
Absolutely a great question. And the ibrutinib arm is within FLAIR. The study design is, there were pre-specified analyses here. So I don't know that we're going to have kind of that head-to-head BTK monotherapy versus venetoclax obinutuzumab. Well, that certainly will not be answered in this study, but I think that is like one of the most important questions, and one that we really do need to answer. So it's a great point. Like, that doesn't help us really answer that question. The next study that we're going to look at is Captivate. So this is a phase 2 study that has a really cool study design. There were both fixed duration and MRD driven cohorts. So for the fixed duration cohort, everybody get 15 cycles of ibrutinib and venetoclax. For the MRD adapted cohort, you get 15 cycles of I plus V, and then based on your MRD status, you're randomized to different arms. This was an updated analysis with additional follow-up, and the focus was really on those who had received fixed duration therapy. So it included all of the fixed duration cohort, plus that number of patients who had been randomized once they had undetectable MRD to receive a placebo, because in practice they only received those 15 cycles. So there were 202 total patients who had received fixed duration ibrutinib plus venetoclax, and they've seen 53 progression events. So 49 with CLL and 4 with Richter's transformation. And one of the big questions in these combination therapies is, what do we do when people progress? Is it feasible to utilize these novel agents again? Because obviously, if we use all of our best drugs up front and can't subsequently retreat people, that's a problem. So this was the first look at how do we, or a look at how we can retreat people. This is a look at basically the patients who did versus did not progress in the line on the left, or in the table on the left. And you can see that the patients who did progress had higher risk features. I think that's unsurprising, right? People who have higher risk disease have their disease come back quicker. And on the right-hand side, we see for those who did progress, when they progressed. And we can see that complex karyotype and deletion of 17p, those are the patients where progressions tend to happen more and tend to happen earlier. So in that first 2 years. They also, in this study, collected 40 patient samples at the time of progression and did not find any BTK or PCL gamma 2 mutations, which is a big question. Like, if you receive that fixed duration therapy, are you going to be resistant to BTK retreatment? There was one BCL2 mutation identified in this cohort of 40 patients. It is the non-canonical one, so it's not the mutation that we know confers resistance to venetoclax. This is a mutation that's always been described as co-occurring with the mutational, the canonical mutation. So the clinical significance of this, I think, still needs to be worked out, but there was one of those observed. Here's a look at the overall progression-free survival with this 5 years of follow-up. You can see that there's a numerically shorter progression-free survival for those with complex karyotype and deletion of 17p in this cohort. And then they looked at the retreatment data. So in those patients who had progressed, they were retreated 21 with single-agent ibrutinib, 6 received ibrutinib and venetoclax. And here you can see that the overall response rates are really, really high. The patients treated with ibrutinib who are not recorded as responders, there were reasonable reasons for all of them. One was like non-evaluable. One, unfortunately, had a Richter's transformation. There was a COVID-related, like, unable to assess response, that kind of thing. So fixed duration I plus V, we think, might mitigate the risk of developing resistance mutations if people are receiving fixed duration therapy. They're not necessarily progressing. Acquiring these resistance mutations, and patients can be successfully retreated with ibrutinib-based therapy. So I think this provides a lot of reassurance regarding the approach with dual novel agent approaches. Now we're going to move on to GLOW. So Captivate was a phase 2 study. GLOW was the big phase 3 study. a bit of a different population. So the patients in GLOW are older or have comorbidities. And this is a phase 3 randomized study. So they were randomized to receive either I plus V for a fixed duration, this is 15 cycles, or chlorambucil and obinutuzumab. And patients were randomized 1-to-1. This is an updated analysis. So we now have up to 55 months of follow-up with the GLOW study. Here's a look at progression-free and overall survival. So progression-free survival, obviously, significantly better with I plus V. Initially, the overall survival curves had looked concerningly like the survival for I plus V had been lower than chlorambucil versus obinutuzumab, though those curves have now crossed. So with 54 months of follow-up, the estimates are 85 versus 64%. So seeing some updated follow-up there where those curves are splitting even a bit more. They then looked a bit more into landmark analyses from the end of therapy. So they're looking at MRD status at the end of therapy and how that predicts ongoing progression-free survival. So these red curves, so everybody in this analysis got to the end of that 15 cycles of ibrutinib and venetoclax, or the 6 cycles of chlorambucil and obinutuzumab. And you can see the red curves are ibrutinib and venetoclax. The black curves are chlorambucil and obinutuzumab. And it's stratified by MRD status. So the darker curves are undetectable MRD, the lighter curves are MRD detectable. And for I plus V, regardless of whether you achieve MRD or not, you are doing better than if you receive chlorambucil versus obinutuzumab. I think that's not particularly surprising. We do see that the difference between those who had achieved versus not achieved undetectable MRD at 42 months is 78 versus 70%. So you can see kind of the differences there based on how deeply patients respond. They then went on to look at even more landmark analyses to really suss out like who is benefiting, how do we need to achieve undetectable MRD, that kind of thing. So the top curves look at based on IGHV mutational status. And I think the big take home here is that mutated IGHV patients, regardless of whether you achieved MRD undetectable status or not, do very, very well. So the mutated patients are those top 2 curves, the dark blue one and the light blue top one. The patients who had unmutated IGHV who achieved undetectable MRD do better than those who are MRD detectable. So especially for the unmutated IGHV patients, MRD status really does matter. And then we're looking at time to next treatment, and the same kind of theme emerges here. So for mutated IGHV, patients do very, very, very well. Unmutated IGHV patients who are treated with ibrutinib and venetoclax do very, very well. And unmutated patients should not be receiving chlorambucil and obinutuzumab. So chemoimmunotherapy for that cohort is not the right choice based on these data. So overall, this is telling us that MRD status at the end of treatment predicts PFS, especially for those with unmutated IGHV. It seems to be a less significant predictor for those with mutated IGHV. And we see that I plus V improves time to next treatment for those with unmutated IGHV versus chlorambucil and obinutuzumab.
The thing that I'm trying to figure out is, I'll tell you the real question I have that really, I don't know why I never noticed this before. The real question I have is, why do you see in less than 5 years, 37% of these people dying in the control group? Do you see people die of CLL like that?
This was
I mean,
through
30,
COVID.
that's like third.
It's a high proportion for sure. It was through COVID, so I think that's part of it. So there were
Okay.
19 deaths in I plus V, and there are 39 deaths in chlorambucil and obinutuzumab. Of those 39 deaths, 13 were infection related in chlorambucil obinutuzumab. 7 were second primary malignancies. 4 were cardiac. 4 were sudden or unknown. Progression was a very rare cause of death, so that was only 2, and vascular disorders were 3. So and then in the I plus V arm, there were 3 infection-related deaths, 3 sudden or unknown deaths, 1 progression of disease, 2 vascular disorders, and 2 other. So a significant difference in overall survival with a hazard ratio of 0.453 has a significant p-value. And then in terms of deaths, we're seeing excess infection-related deaths in the chlorambucil obinutuzumab arm. We're seeing more second primary malignancies in the chlorambucil obinutuzumab arm.
So, in summary, I would say so this trial showed a very significant effect not only in PFS but also in overall survival, except that most of the deaths were not from CLL.
Yeah, the CD20 effect and the subsequent infection risk is real. And I think that we really learned that lesson through COVID. People were very hesitant to use CD20 antibodies through COVID. I think a lot of our primary concern was about ability to respond to vaccines, but I think this proves this is a big deal. Like it's bad when people have CD20s in terms of their infection risk, especially in the setting of a pandemic. So I think that's...
Is that the way, when the data was presented, did they discuss that or bring that up or in the discussion?
Yeah, so they went through the summary of deaths. The COVID-related deaths were 2 on the ibrutinib venetoclax arm, 7 in the chlorambucil obinutuzumab arm. So there's a difference there. But its total infectious-related deaths was 3 versus 13. So there's also other infections that were not, are not directly COVID-related, but infection-related deaths. So next up, we're going to look at a relapse refractory study, and this is an update with up to 4 years of follow-up. Patients received 15 months of ibrutinib and venetoclax, and then the next steps were dependent on MRD status. So those who were MRD positive at that point continued ibrutinib monotherapy. Those who were MRD undetectable were randomized in a 1-to-2 ratio to continued ibrutinib versus observation with venetoclax and ibrutinib retreatment upon MRD relapse. So this did not require CLL progression according to IWCLL. If they had an MRD relapse, they were retreated at that point. The primary analysis was done when the last patient reached 27 months, and that had shown a favorable risk-benefit profile of MRD-based cessation of ibrutinib and venetoclax. The primary endpoint had already been reached, and the progression-free survival post-stopping in Arm B, meaning the patients who had stopped and then been retreated, was 98% at 12 months. So here we have a look at the patient characteristics. So we see the full cohort of 225 patients, and breaking this down, 72 patients had achieved undetectable MRD and were randomized either to Arm A or observation. So I'm going to pull up the curves and show you that basically Arm A, the ibrutinib continued patients were in blue. The green arm is those who went into observation, and then the red arm are those who continued ibrutinib maintenance. So that was either because they were MRD detectable or they went off protocol before randomization. So that was a total of 37 patients. We see 153 altogether in that cohort. And we can see that overall in progression-free survival for those who achieve undetectable MRD, regardless of whether they're randomized to continued ibrutinib versus treatment cessation with retreatment at MRD relapse, is excellent. So that's reassuring. Those who do not achieve undetectable MRD notably have an inferior overall and progression-free survival. So we're seeing that. We also see the time to next treatment on the right-hand side, and we see that those who were not randomized, meaning they had detectable MRD at the end of those 15 cycles, did have the proportion requiring retreatment was higher. Here's a safety at 3 years after the 15 cycles of I plus V. Those who continued ibrutinib had a 31% discontinuation arm. So this is the patients who remained MRD detectable. Those about a third stopped. Most common reason was because of toxicity. For the patients in Arm A, meaning they had achieved undetectable MRD and then were randomized, 54% had discontinued. Again, the most common reason was toxicity. So we're seeing, that that theme that we've seen before in terms of prolonged BTK monotherapy can be associated with toxicity. Here's a look at treatment reinitiation, and I think reassuringly, we're seeing that for patients who are observed after I plus V and are retreated, many are able to achieve really deep responses. So 40% of the patients experienced an MRD relapse. There were some who came off therapy. So of the 19 who had MRD relapses, 4 of them are off protocol. But of those patients who had the MRD relapse, the median time to that relapse was about 2 years. And we see that the patients who relapsed were enriched for the high risk features, so TP53 aberrations and complex karyotypes. And patients are able to achieve deep responses. So 47% actually were able to achieve a undetectable MRD state when they were retreated with I plus V. So overall, these data show us that patients who achieve undetectable MRD and stop therapy do very well. They can stop, and then they can, in many cases, be successfully retreated upon MRD progression, which I think is similar to the lesson we had learned with the earlier data set. So reassuring. The next study is an alliance study, and we see this is a phase 3 looking at older adults who were randomized to receive ibrutinib obinutuzumab versus IVO, so ibrutinib obinutuzumab and venetoclax. And we're seeing that for those who received ibrutinib and obinutuzumab, they continue ibrutinib regardless of response. For those who receive the triplet therapy and achieve undetectable MRD, those patients discontinue ibrutinib. Anybody who has detectable MRD does continue ibrutinib. So fixed rate MRD stopping rule here. And the primary endpoint was progression-free survival. This study was designed to detect if IVO improves progression-free survival compared to ibrutinib obinutuzumab. And the data were released after the study met its predefined futility threshold. So the hazard ratio was predefined, and these data were released because of that. So we're actually seeing that there is not a benefit to IVO over ibrutinib obinutuzumab. So the triplet does not improve outcomes versus IO, and for the treatment of older patients with CLL. And interestingly, COVID-19 was the leading cause of death in both arms. So there were 11 COVID-related deaths in the ibrutinib obinutuzumab arm versus 19 in the ibrutinib ven-obin arm, with 13 and 11 additional deaths from other causes, respectively. So here you can see the progression-free and overall survival curves where IO is maybe, they're not significantly different, but we see that IO is maybe a little bit on top. If we censor out the COVID-related deaths, they're actually entirely overlapping. And so there were more deaths observed in those who had received the triplet versus doublet. And the progression-free survival for patients treated with IVO was not impacted by either MRD or response status. So these data suggest that for at least for older adults, the triplet does not provide benefit over the doublet, especially in the setting of a pandemic, I guess is what we're learning from this. So the next study we're going to be looking at is the CLL2 BAG trial. And this is a study of acala, ven, and obin in relapse refractory CLL. And this is follow-up data that's looking at efficacy as well as circulating tumor DNA analysis, which was a fun topic to explore at ASH this year. So patients receive optional debulking with Benda. Then they undergo the induction therapy, which is considered obin in cycle 1, addition of acala in cycle 2, ven in cycle 3. And then patients are treated until they achieve undetectable MRD with a max of 24 cycles of maintenance. So that maintenance starts down the road. And the primary endpoint here was undetectable MRD. 76% of patients had achieved undetectable MRD after 6 months of triplet therapy. And here we are taking a look at the efficacy data. So we see that the median treatment duration, which was guided by MRD, was just under 15 months. And this is a curve looking at the time to undetectable MRD in the peripheral blood. So we're seeing that patients are able to come off therapy relatively soon, and that the rates of undetectable MRD in the peripheral blood are very, very high with this triplet. 7 of the 10 patients with positive MRD after that first induction period then achieved undetectable MRD during maintenance. So for the patients who are not getting there, it does seem like further therapy allows for deeper responses in a majority. And here's a look at progression-free and overall survival, which at 30-month estimates is obviously excellent, with 100% overall survival and 88% progression-free survival. So my take home here is that treatment with AVO in a relapse refractory population is able to achieve high levels of undetectable MRD. And then some of the data that the authors had presented was about the ctDNA. And this was showing that for the patients who have molecular relapses, we catch some of them with MRD, but not all of them. And ctDNA does seem to enhance our ability to detect early molecular relapses beyond what we're able to detect only with MRD testing.
I'm so glad to see this slide because literally when I sat down this morning, I had already written out the question I'm about to ask you. Imagine you're talking to a medical student, not even a fellow, and can you please explain, I know this seems crazy, what exactly you do when you test for MRD versus ctDNA? Like, what's
Great
the
question.
difference?
Yeah, totally. So MRD, you're looking for CLL clones that are circulating. So you're looking for the actual
Cells.
disease cells in the peripheral blood. So you can do that by flow, where you're detecting based on the, immunophenotype of the cell, or you could do that by clonoSEQ or next generation sequencing testing, and that is a look at IGHV mutational sequencing basically, and I think of this as a barcode. So like you get a barcode at baseline, and then you scan all your blood cells and you say, per million nucleated cells, can we find any cells with the barcode that matches the disease barcode? And that's your MRD test. ctDNA is looking for free DNA. So this is more of a look at nodal relapse is the thought process. So you're not actually having the cells circulating through the blood, but there are cells somewhere, and that might be a nodal or a splenic compartment. And ctDNA seems to pick that up. The next study I want to bring up is actually a trial in progress. So this is a combination of zanubrutinib and venetoclax. So the third approved BTK inhibitor. We've talked about ibrutinib. We've talked about acalabrutinib. This is Zanu with Ven, the doublet. And the idea here, this is an IIT where they're looking at the patients receive Zanu and Ven up front, and then if the next steps are dependent on the MRD status. So those who are undetectable are observed. Those who have detectable MRD then actually have the addition of obinutuzumab. So maybe we don't need this triplet for everybody. Maybe we should be adding in the obinutuzumab when we've proven that they need it after doublet therapy. And that's the idea behind this protocol. Will be very exciting to see kind of how successful this approach is and how patients do with this. The next combination that I want to bring up is the combination of pirtobrutinib with venetoclax with or without rituximab. And these are data from the phase 1b study. So this was Bruin, which was the phase 1/2 study that led to the approval, FDA approval for pirtobrutinib for relapse refractory CLL. This was a relapse refractory population. Patients could have received a prior covalent BTK inhibitor. They did not receive a prior BCL2 inhibitor. And this was a phase 1b portion where patients received either PV, Pirto and Ven, versus PVR, Pirto, Ven, rituximab. And it was 15 patients in the doublet arm, 10 in the triplet arm. And here's a look at baseline characteristics. So the groups were fairly young with median age overall of 66. People had good performance statuses. About 2/3 had received a prior BTK inhibitor. And we saw some CIS481 S mutations in this cohort. So 40% had a cis481S mutation. Here's a look at the waterfall plot for these patients. So the doublets are on the left, the triplets are on the right. You can see that the overall response rate is 96% for both of these arms. They're not meant to be compared. And here's a look at progression-free survival. So patients did well, relapse refractory patients did well with this doublet or triplet. 71% were able to achieve undetectable MRD after a year of therapy, and all patients received 2 years of therapy and then stopped. This is a combination, the PVR combinations actually being explored further in a phase 3 study. And thinking about safety, there were no DLTs in either arm. There was with the doublet arm, there were a couple of cases of tumor lysis syndrome, and this might be because there was a relatively short lead-in with Perdo, so that has been addressed in the phase 3, and I think we'll see a safe combination that will be compared to venetoclax rituximab, the Murano regimen, to really inform treatment in the relapse refractory setting. So overall, Perdo and Ven, with or without rituximab, seems to be very effective with a high overall response rate in a relapse refractory population, and there were no DLTs observed. Okay, now shifting gears a little bit, we're going to look at some new agents in CLL. So we've talked a lot about combination therapies. Here we have nemtabrutinib. So this is another non-covalent BTK inhibitor, and this was a paper that was published in Cancer Discovery. We see the phase 1 data was of this agent being used in 47 patients, 29 of whom had CLL or SLL. You can see the baseline characteristics here. I'll draw your attention to the fact that there were a lot of patients pretreated with covalent BTK inhibitors, including Acala and ibrutinib. 82% of the CLL patients actually had a BTK mutation going into this. We see that the overall response rate in CLL is 36%, but that's for the whole study. For those who had received at least the recommended phase 2 dose, the response rate was 75%, and the median progression-free survival was just shy of 17 months. In terms of toxicity, we saw some heme toxicity, so anemia, higher grade anemia in 11%, higher grade neutropenia in 24%, higher grade thrombocytopenia in 13%. Most common non-heme AEs were weight gain, cough, fatigue, and back pain. So we've got another non-covalent BTK inhibitor that is being developed and has activity in CLL regardless of cis481S status, as well as in other non-Hodgkin's lymphomas. The next study I want to highlight is looking at Lysocell. So this is 24-month median follow-up of Transcend CLL 004. And this is a look at Lysocell. So patients with relapse refractory CLL had their cells manufactured, received lymphodepletion, and then received Lysocell. The primary endpoint was CR or CRI rate, and there were also a look at secondary endpoints, including overall response rate and undetectable MRD rate. And there was a look at basically the full study population, which included 137 patients, and then also those who had progressed on a BTK and had prior venetoclax with failure, and that was a specific cohort that was evaluated. The primary endpoint was the CRI rate in that double refractory population. So starting out with the 82 patients, but once you get to the patients who were efficacy evaluable, it's 54. You can see that in the full study population, 60% had progressed on a prior BTK inhibitor, 100% in this double refractory population. Here's a look at the full study population on the left and the double refractory population on the right. I think some of the key take-home points here are that those responders do incredibly well, but the rate of response is somewhere in the 20-ish% range. So the CR rate is about 20%. The overall response rate in the double refractory population was 44%, and the overall response rate in the full study population was 48%. So we see that for those who respond, they do very well and have durable remissions. And that's kind of my take home here. You can have double refractory disease, and if you achieve a CR with liso-cel, you do have that prolonged progression-free survival. Next up, we're looking at sonrotoclax, which is a second-generation BCL2 inhibitor, and this was studied in combination with zanubrutinib. This is an ongoing phase 1/2. So patients were getting sonrotoclax as monotherapy as part of this study, but this report's really looking at the combination of therapies. And patients, there was a dose escalation for sonrotoclax, and then the expansion was exploring 2 different dose levels, so 320 versus 160, along with zanubrutinib at standard dosing. Here's a look at the baseline characteristics. So median follow-up at this point is about just shy of 10 months. Patients were overall young, and the proportion with high-risk disease was like 25% had TP53 aberration, 62% had unmutated IGHV. Here's a look at the safety. So we see that AEs were common in this with this combination, and we did see some dose holds with relatively few discontinuations. So only 1 patient required a dose discontinuation. Here's a look at the toxicities. Overall, lots of low-grade stuff, but high-grade toxicity really only included neutropenia and then hypertension. And here's a look at the overall response rate, which is 100%, so incredibly effective. This is a look at MRD, and we can see that there are really high rates of MRD undetectable status as well, with 100% achieving UMRD at that higher sonrotoclax dose level by week 48. So overall, a really effective combination. Here's the PFS curve. It's always good when those look like straight lines. So here we see that this is incredibly effective. This is given as a continuous therapy, so a little bit different than some of the combinations that we had seen previously. So overall, sonrotoclax and zanubrutinib is well tolerated with low rates of high-grade toxicity, and the overall response rate is 100% with this limited follow-up. And now we're going to finally go into the Richter's transformation section of this. So we know that Richter's transformation is a tricky situation, and patients often do not do particularly well with chemoimmunotherapy. So looking at some new approaches. The first is a study called MOLTO. So patients received obinutuzumab, atezo, and venetoclax. And this was a study done in 28 patients. You can see the schema on the right-hand side in terms of when patients received what. But this was all previously untreated Richters. So this is a frontline study. And here's a look at the baseline characteristics. So in terms of this patient population, the prior lines of therapy for CLL, the median was 1, and the time from CLL diagnosis to Richter's was about 4 years. We then see that see the baseline biological characteristics in the bottom of this table. So about half have a TP53, just under half have a TP53 aberration, and just under half have complex karyotype. Here's a look at the swimmer's plot. So you can see that patients received this triplet combination in the blue line. If patients progressed, we can see what that they received second-line therapy, and we do have a number of patients who have remained alive in continuous remission, and also some who have undergone curative intent allogeneic stem cell transplant. So out of the 19 responders, 40% are in a continuous remission. Out of the entire population, 40% are in a continuous remission. So we're seeing some efficacy here. So obin, atezo, and ven has activity in this untreated Richter's transformation population with an overall response rate of 68% and a median PFS of 16 months, which compared to historical chemoimmunotherapy studies is favorable. So the next study I want to look at is also in Richter's transformation, and this is a combination of tislelizumab, which is an anti-PD-1, as well as zanubrutinib, so the combination of these therapies. Patients could have received no prior lines of therapy or one prior line of therapy, and they received 6 cycles of induction followed by 6 cycles of consolidation. For those who achieved a response or at least stable disease, they could continue until progression. And here's a look at baseline characteristics. So median number of prior lines of CLL-directed therapy was 3. We see that complex karyotype was present in under half. And in terms of high-risk cytogenetics, 20% had del17p. Overall, 35-ish% had either a TP53 deletion or mutation. Most patients had prior exposure to a BTK inhibitor or a BCL2 inhibitor. No one had prior RT-directed therapy, and all of these patients had large cell histology. So we did not see any Hodgkin's transformations in here. Here's a look at the swimmer's plot. The overall response rate was 58%, and the 6-month duration of response rate was 75%. 1-year overall survival is 75%, so median PFS about 10 months, median time to next treatment about a year. So this is a combination that does seem to have activity with a median PFS of 10 months, which it provides us another option for patients with Richter's. Finally, we'll look at pirtobrutinib. So this is in Richter's transformation, and this is looking at a single agent drug in Richter's. And patients here, we can see that the median number of lines of prior CLL-directed therapy was 2. The median prior lines of Richter's directed therapy was also 2. Patients were eligible up front if they were considered chemo ineligible, but everybody else had received chemotherapy. So in this agent shows that the overall response rate's about 50% with a CR rate of about 13%. You can see the waterfall plot on the right-hand side. And we see that with about 10 months of follow-up, the median duration of response is 7 months. So this is a great bridge for patients. I don't think it's a durable answer, but it does seem to have single agent activity in Richter's, which is a situation where patients often don't have a lot of options. And with that, I want to conclude and thank you all for your time and attention.
Another sort of random question as I was listening to you. Any situations where you have or would try to access pirtobrutinib for transformed disease outside of trial?
I have used it, yeah. It's not a durable solution, but some of those, I'm a little bit biased because I treated a lot of patients on Bruin, and some of those longest lines in the swimmer's plot were my patients. So I've actually had quite a bit of success with that agent. I've used it as a bridge to get to transplant. I've used it as a bridge to get to CAR T. I think that it does have a role in Richter's, and I think that the single agent efficacy for people who end up getting fairly beat up from chemoimmunotherapy in a lot of situations is really incredible.
So another kind of random question. Do we have any data on covalent BTK after pirtobrutinib or other non-covalent?
Great question. No. But that is actually the topic of a study that I think is going to be done. So it's going to be looking at a CALA after non-covalent.
Have anecdotal responses been seen? Have you ever tried it?
I have an N of 1 who had, I have a patient who had received ibrutinib like a long time ago, had developed a cis481S mutation, was on Bruin, progressed through BTK through non-covalent BTK, then was treated with venetoclax. In the process of being treated with venetoclax, actually had the BTK mutation disappear, and it now has relapsed with CNS disease. So because of that, I'm treating with ibrutinib, which we know has CNS penetration, and I've proven through a CNS biopsy that he does not have cis481S mutants in his brain. So I'm now treating with ibrutinib monotherapy, and he's responding.
Wow.
Which is pretty incredible because we tried some other things before we got to ibrutinib that didn't go so great. So we're pretty excited about that response.
Yeah, kind of reminds, I think of these things, I know they're completely irrelevant, but like in lung cancer, they started out with a TKI for EGFR, and then they got a much better one, osimertinib. But
Yeah.
then there were situations where people relapsed on osimertinib and they responded to the first line, which
Yeah.
seems counterintuitive, but I was just curious if
It
we knew
totally
that.
does. And I think that's going to be really important data as we figure out all of our sequencing questions, for sure.
Another question, I'm really ruminating a lot on this survival thing that we were thinking about
Yeah.
because, it kind of, outside of CLL, in the general medical oncology realm in terms of how people view CLL, I mean, I think, people view that it's great because, you can keep them feeling good, et cetera, but you're not going to affect their mortality. But I'm wondering, maybe you really are affecting their mortality. Maybe it's not enough to pick up in the trial, but the way you're affecting it is through infections,
I
particularly if
think
there's something
that's
like COVID going on.
I
It's like a
think that is
different concept.
entirely true. I
It's
I mean,
almost like
it,
visualizing it, treatment as like a palliative versus, more substantial. And I think
I think
that maybe
there
that's
is
happening.
there is a piece of this that's real. I mean, there are a lot of patients who do great with CLL for sure. There are also patients who don't, and I think the infections risk and that's a real thing. And I think that we're also seeing that treatments have toxicity, and some of it's not like those on treatment toxicities where they're having cardiac toxicity and dying while they're getting therapy, but there are long-term implications of what we choose. And I think that is gonna it's going to be interesting to see. I mean, the doublet versus triplet combination proving that triplets are no better and definitely no better than doublets, I think is important, right? Like, I think there are long term consequences of those decisions.
Another question is your in general outside of clinical trial. I know I'm sure most of your patients go on trial. Do you have a favored first line BTK inhibitor at this time?
Great question. So I use them differently in different situations. I think that the toxicity profiles are very different. So if I have patients who have comorbidities that make me think that one thing or another is going to be a problem, I definitely direct them one direction or another. I also think that there's a lot that we need to learn about resistance mechanisms, and that was a huge theme of ASH this year for CLL. Was how are patients developing resistance mutations, particularly as we're learning more about how patients progress through non-covalent BTK inhibitors with Perto. We want to know how, are we conferring resistance to a second line of therapy through a first line of therapy? And there was that concerning presentation about the resistance mechanisms picked up through zanubrutinib. And that was kind of the initial data from Australia, was suggesting that maybe some of the mutations that confer resistance to Perto are actually acquired with Xanu. The data during ASH made it clear that it's not a majority of patients, but we are seeing people who are developing those resistance mutations with zanubrutinib. So I'm thoughtful for my very, very young patients because I know that we're going to need to use all of these lines of therapy, and I certainly don't want to affect the efficacy of my next line of therapy with my first.
Could you give me maybe an example or two of a patient you would favor Acala for, an example or two of a patient you would favor Xanu for?
Yeah, absolutely. So, acalabrutinib, the headaches can be really bothersome, and there can also be some neurologic effects that are like imbalance and kind of some vague like disequilibrium, that kind of thing. So, patients who have migraine histories or patients who have baseline neuropathy or some balance issues, I tend to favor going with another BTK inhibitor. For zanubrutinib, the toxicity that seems to be most significant is GI in terms of lifestyle effect. So patients who have underlying IBS or a history of abdominal pain, things like that, I do tend to favor acalabrutinib. And then for my really young patient who I am fairly confident I'm going to need pirtobrutinib down the line, if they're not interested in a clinical trial, which is always my first go-to, and they're not interested in fixed duration Ven-Oben, which is another common consideration, that's a patient where I maybe favor ACAL a little bit more while we're figuring out the resistance mutation piece.
What kind of situation do you think about transplant and when?
Great question. Um, so it's interesting because it's the double to triple refractory patient who is young and fit. And I have not actually transplanted someone in a very long time, and I just had a patient who I was considering it and sent her to transplant for consideration, and they were like, I don't really want to. It's like, okay. Um, so mostly because she's been doing well on clinical trials, and we have CAR T if and when relapse has happened. And obviously that's not foolproof, but as I've been kind of exploring, like, who are the patients where we should be considering this, one of the big pieces, I think, is we do see relapses after transplant, and then we do see toxicity. So I think we have a lot of promising investigational agents in the pipeline, and we're able to treat people well with those. So I think for a lot of patients, transplant is becoming less and less of a consideration.
So one final question, which is that I hear people telling me, surveys get done and stuff gets published, et cetera, that, for example, in the United States, a significant fraction of patients get treated with first-line BR, like maybe a quarter of them.
Or
And people,
CD20 monoclonal antibodies,
okay,
single
CD20
agent.
monotherapy,
Yeah,
right. And I've heard numbers like 25-30% of people, which seems incredible. And
right.
I guess my question is, A, do you think that's correct? And B, a lot of people, for whatever, whenever you see it, conclude that it's because the doc's not following whatever, not up to date, although it's so hard to believe to be that out of date. But I wonder how much of that is because you mentioned the issue of insurance, and
Mhm.
financial. Do you think that, like, maybe in the community they don't have the ability to access some of the ways to get the drugs, or do you think that is part of it?
I think that's absolutely part of it. Um, I think there is probably a minority where it's, I've used BR. I know how to use BR. I'm just going to continue using BR, right? There's going to be a subset of patients that are in that bucket. Then there's the financial piece, right? So there's the realities of the hoops you have to climb through to get novel agents approved. There's the appeal of fixed duration therapy. And I think that that's real. And venetoclax obinutuzumab is obviously a very effective, approved fixed duration therapy, but it also requires quite a bit of stuff, right? Venetoclax dose escalations in CLL are resource intensive, and I think that that's probably a proportion of patients as well. So I think it's all of the points you mentioned.